Welcome, ladies and gentlemen. I am Liza Malik, PhD scholar from Department of Physiology, Government College University, Faisalabad. On the behalf of Organizing Committee IBBC 2023, I welcome all of you to the first International Brain and Biomedicine Conference. I am the moderator of this session, which includes the talk from psychology, psychiatry, and neurosciences. So let's begin our session with our first presenter, Sidra Nadeem from University of Management and Technology. She will present on topic work-related burnout, spiritual bypass, and mental health in employees.
Assalamu alaikum. My name is Sidra Nadeem, and today I'll be presenting on the topic work-related burnout, spiritual health, and spiritual bypass and mental health in administrative employees. My co-authors are Shiraz Aziz and Ma'am Amara Qureshi. Work-related burnout, it is a condition that is characterized by emotional exhaustion, depersonalization, and reduced personal accomplishment. Now, when we talk about burnout syndrome, it is to be a state of experiencing physical and emotional exhaustion that takes place due to the different emotionally demanding situations that arise in work or in an organization. Spiritual bypass, it is the act of attempting to address psychological wounds solely on a spiritual level without taking necessary steps on any other levels such as cognitive, physical, emotional, and interpersonal. Basically, the concept of spiritual bypass was coined by John Welbert in an article, and where he defined it as the act of utilizing any kind of spiritual activities and beliefs as a means of avoiding any kind of unresolved trauma or emotional problems or developmental tasks. And lastly, mental health, which will be explained in the terms of depression, anxiety, and stress, are an individual's ability to apply their skill in accordance with the common values of society, which is enabled by a dynamic condition of internal equilibrium, which means that it is not an independent state, but a crucial part of an overall health in which all the abilities of a person are seen, that the basic and cognitive and social abilities, the capacity to identify, express, and regulate one's own emotions, etc., etc. After that, we move on to our rationale, which is that it is the gap present. It is a gap which is present in, first of all, there's a gap present in the research about the extent of burnout which is experienced by employees in different industries. Secondly, to shed light on work-related burnout in public and private administrative personnel. Thirdly, a little research has been conducted on the individual employee sector regarding spiritual bypass, and we wanted to see that whether do any of them utilize it in their employment or not. And lastly, that spiritual bypass must be understood within the context of the culture in which it emerges. After that, we move on to our After that, we move on to the hypothesis, which is that there's likely a negative relationship between work-related burnout and mental health, as well as work-related burnout and spiritual bypass. After that, there will be a positive relationship between spiritual bypass and mental health, which is in administrative employees, and that work-related burnout and spiritual bypass are likely to be significant predictors. The research method that we use was a correlation cross-section design, in which the sampling method that we used was non-probability purposes sampling. The total number of participants included in the research were 180, and the inclusion criteria was that the employees should have at least 8 working hours, and only administrative employees should be included. Exclusion criteria included employees who have double duty, like administration and teaching, and employees from semi-government. The assessment measures. After that, the procedure was basically that first of all we conducted a pilot study, and once there weren't any issues to be seen in it, we started with the data collection, and the assessment measures included the demographic form, Copenhagen burnout inventory, depression scale, depression, anxiety, stress scale, and spiritual bypass. The CBI, or Copenhagen burnout inventory. Out of this, only work-related burnout subscale was used with a rating scale of 0 to 4, and the current research Cronbach's alpha was 0.78. The DAS 21, or the depression, anxiety, stress scale 21, was used, of which translated version was used by Nadeem Aslam. Rating scale was 4-point Likert scale, and the current research Cronbach alpha was 0.91. And lastly, spiritual bypass scale, which was developed by John Welbert, but the one which we used was by Mahdi and Salim. with a rating scale of 4-point Likert scale, and the current research Cronbach alpha was 0.83. The results indicated work-related burnout and mental health negatively correlated with each other. Work-related burnout and spiritual bypass were negatively correlated with other. While on the other, lastly, spiritual bypass and mental health were found to be positively correlated with each other, and spiritual bypass was found to be a positive predictor of mental health. Now, moving on to the first hypothesis, which was that it was supported by the findings of our research, and it indicated, and were in line with the previous research. The results indicated a negative correlation between mental health and work-related burnout, which is that, for example, in organizations, there can be a decrease in individuals' ability to perform their job properly. Why? Because the work-related burnout syndrome can be caused due to the workplace stressors, which can lead to depersonalization, as well as coping strategy, in which they can further lead to low personal fulfillment. And in another theory called demands resource theory, it is explained that certain job demands, such as the one that requires mental or physical efforts, can lead to psychological costs, which may be in the form of physical and mental exhaustion. So this can lead to burnout. Mazzano and Ramos also explained that burnout can be a reaction in a way to the ongoing job stress where coping mechanisms fail to occur. So, for example, they can lead to a low professional failure, low levels of personality. So, in individual to cope with this, all of this, they will develop a depersonalized attitude, which can lead to a decline in mental health. The second hypothesis is that it was accepted as well. Now, work-related burnout and spiritual bypass are basically what they talk about is that spiritual bypass, when people are on a journey of spiritual bypass, there are common issues that arise, which are narcissism, extreme external locus of control, spiritual obsession, or addiction. In the social exchange theory, it says that when an employee perceives a disparity between their efforts and their contributions, but there is no reciprocity, so they feel that they're unable to concentrate of their work. So when they're unable to do that, how can their first priority be their spiritual health? How can it be when there are so many things going on around them? In another, that there are some people who are very, very much into their work. They're overloaded with their jobs. They do 2 jobs at the same time, and when they these workers feel that they need to achieve more in order to be able to get further in life. So this is correlated with a high proportion of burnout, so which can lead to a sense of abandonment in person's life and their poor health. So in light of this study, it is highly possible that the ones that fall under this category have a higher level of work-related burnout, which indicates that there is less likely to be involved in a spiritual journey or on a spiritual path. The third hypothesis, which was that the results suggest that there is a positive correlation between mental health and spirituality. Basically, this research showed that the culture that is present in our society, even despite it is believed that there might be it might be a collectivistic culture, there is a high time that it is the individualistic culture, in which thrives on that the person should focus on themselves. So when the person is focusing on themselves and they're putting themselves in front of them, in their needs in front of anyone, their problems, their issues, so then how can they be how can they have anxiety or depression at that time? So this is that they're the ones who control their future, and they should try to solve their problems. So this teaches the individual that they should not put themselves the other. And so if a person is able to spiritually bypass higher, then their higher their mental health would be. And lastly, the conclusion is that the result indicated a negative relationship between mental health and work-related burnout. Spiritual bypass was found to be positively related with mental health, and a negative relationship was found between work-related burnout and spiritual bypass. These are the references, and thank you so much. Allah Hafiz.
Thank you so much, Sidra, for sharing your amazing work. Our next presenter is Suhail Anjum from Lincoln University College, and he will present his topic on assessment of depression among cancer patients in a public sector cancer hospital of Lahore.
Bismillahirrahmanirrahim. We welcome all of you in International Brain and Biomedicine Conference 2023. Well, I am Dr. Suhail Anjum, PhD scholar, Lincoln University College, Malaysia. Today, my topic of discussion and presentation here is assessment of depression among cancer patients in a public sector cancer hospital of Lahore. Background: a cross-sectional study was conducted to assess depression in 60 patients of different types and stages of cancer. The aim was to assess the effect of education, economic status, and duration of cancer causing depression. Methods: a cross-sectional study using questionnaire was carried in June 2018 in Mole Hospital, Lahore. Methodology: in Mole Cancer Hospital, Lahore, the study was conducted to assess the depression using questionnaire instrument DSM-5 self-related level 1 cross-cutting symptom measure, adult 13. In Mole Institute of Nuclear Medicine and Oncology, Lahore is the public sector hospital for cancer patients, giving them free medicine and rehabilitation. Nearly all cancer patients of hospital were taken as study population at that study time. 60 patients consented to participate in research. Data was collected from them by the above mentioned instrument. Maximum age was 88 and minimum age was 16. Mean age was 45.5 years, having standard deviation 15.3. 43.3% patients were male and 56.7% were female. The resulted frequencies were shown in the tabulated form. The results: the cross tabulation between various factors and the cancer patients with anxiety and depression yielded the following factors as significant with associated value less than 0.5. These factors were family history of cancer, education of patient, awareness about anxiety and depression, and severity of pain. Out of 60, 55% did not have unpleasant thoughts, while 5% had such thoughts. Maximum age was 88 and minimum age is 16. Mean age was 45.5 years, having a standard deviation 15.3. 43.3% patients were male and 34 were, 56.7% were female. Now you see that interest in doing things I have shown in the frequency table. None interest in doing things, none of the interest was shown by 17 patients, 28.3%. And rare interest was shown by 21 patients, 35% of the patients. And several days interest in doing things, again 10 patients they showed, and that made a percentage of 16.7. Half a day, 5 patients, and percentage 8.3. Every day, 7 patients, and percentage 11.7. And total of 60, that makes 100% of the population. Well, we concluded that our study has showed that the cancer patients suffering from depression have worse prognosis. However, the counseling and screening can improve their health. So thank you very much. Be kind to your mind. Thank you.
Thank you, Sohail, for your nice talk. Our next presenter is Samira Shafiq from University of Gujarat, and she will present her topic on psychological distress and quality of life in patients with substance use disorder, mediating role of coping strategies.
Bismillahirrahmanirrahim. Assalamu alaikum. The topic of my presentation is psychological distress and quality of life in patients with substance use disorder, mediating role of coping strategies. I'm Samira Shafiq, lecturer and PhD scholar in Department of Psychology, University of Gujarat. My co-authors are Jamila Fatma and Kuratulan Mohammed. Introduction. According to the estimates of Anti-Narcotics Force Pakistan, approximately 7 million people are suffering with substance use disorder, making youth at high risk for drug addiction in future. This signifies the importance of studying patients with substance use disorder and their psychologically related issues such as psychological distress, quality of life, and coping styles. Psychological distress is defined as a reactive maladaptive mental functioning when encountered with stressful life events. It is measured by depression anxiety stress scale in the present study. Quality of life is a person's perception of his or her status in life within the cultural value system that aim to achieve their goals, expectations, standards, and concerns. It is measured by WHO QOL-BREF in the present study. Coping strategies are behavioral and cognitive mechanisms used to deal with stressful events. It is measured by coping scale CS in the present study. The objective of this research are number one, to investigate the relationship among psychological distress, quality of life, and coping strategies used by patients diagnosed with substance use disorder. Number two, to find the mediating role of coping strategies between psychological distress and quality of life. Hypotheses of the present study are number one, there will be a significant relationship between psychological distress and coping strategies in patients with substance use disorder. Number two, there will be a significant relationship between psychological distress and quality of life in patients with substance use disorder. Number three, there will be a significant relationship between coping strategies and quality of life in patients with substance use disorder. Number four, coping strategies will significantly mediate between psychological distress and quality of life in patients with substance use disorder. Method. The research design is cross-sectional study. A sample of 200 diagnosed male patients with substance use disorder was selected purposive sampling technique from Shahid Naveed Rehabilitation Clinic, Patanwali, Wazirabad. Their age ranged between 16 to 64 years. 53% were married and 64.5% lived in joint family system, with 38.5% have done their matriculation. Procedure. They were screened in the rehabilitation center with Urdu version of drug abuse screening test. Informed consent was obtained and demographic sheet was filled out. Urdu versions of DASS, WHO, QOL-BREF, and CS were used with patients diagnosed with substance use disorder. Results. The table was showed that depression and anxiety have insignificant negative relationship with coping strategies, but stress has insignificant positive relationship with coping strategies in patients with substance use disorder. However, significant negative association of quality of life was found with depression and anxiety, but it was insignificantly negative with stress. Coping correlates significantly in positive direction with quality of life. Figure 1 in structure equation model showed that coping strategies significantly mediated between psychological distress and quality of life among patients. This indirect mediation of coping strategies was partially significant for stress and anxiety, but was fully significant for depression in patients with substance use disorder. Discussion. I have just narrated a few of the researches over here, and just to give you the idea that this area has been explored by the other researchers as well. My first hypothesis has been rejected, that is, my studies have not shown a significant relationship between coping strategies and psychological distress. These findings were contrary to the findings of the Christian, and the reason would be uh, perhaps that treatment phase through which patients were passing at the time of the data collection. They were in detoxification phase and yet were waiting for psychotherapeutic intervention to be carried out for better learning of coping strategies and reduction in psychological distress. Hence, the first hypothesis of my study was rejected. The second hypothesis of the present study is accepted because results are consistent with the previous findings with significant association between psychological distress and quality of life. The third hypothesis of the present study is also accepted because the results are consistent with the findings of the previous studies, and same is the case with the fourth hypothesis, narrating the very mediating role of coping strategies on the relationship between depression, anxiety, and substance use disorder with quality of life in these patients. Conclusion: the psychological distress of patients with substance use disorders is insignificantly correlated with coping strategies. However, depression and anxiety significantly associated with their perception of quality of life. Structure equation models confirm the significant mediating role of coping strategies between psychological distress and quality of life among these patients. Implications: there is a dire need to accelerate psychotherapeutic intervention in rehabilitation centers, in conjunction with biomedical treatment provision to the patient with substance use disorder to enhance their coping strategies for effective dealing and solving of life problems and reducing their psychological distress. Limitations and suggestions: small sample size of males with purposive sampling technique was focused in the present study. In future, large sample size, including females with cluster sampling technique from Punjab, will produce better generalizable results. Quantitative investigation of this relationship among variables was carried out. However, future studies can focus on qualitative exploration of causes of substance use disorder in Pakistan. These are the references. Thank you very much.
Thank you, Smira, for presenting such a delightful presentation. Our next presenter is Suhail Aftab from Virtual University, and he will present his topic on association between loci of control and life satisfaction in boarding students.
Hi, this is Suhail Aftab from Virtual University of Pakistan. I'm honored to present this study titled Locus of Control and Life Satisfaction in Boarding Students in Pakistan. Some of you at least might have heard the name of an English boarding school founded in 597, that is King's School in Canterbury. This paper includes the history of this institution and many other boarding institutions in England. But the current study encompasses one of the famous boarding institutes of the country Pakistan, that is Cadet College Hassanabad. There is a particular reason for choosing boarding setting. According to my research, a large number of senior judges in Pakistan, they were schooled in Aitchison College, Lahore, and at least 75 military officers that rose to the rank of general, they belonged to Cadet College, Hassanabad. The purpose of the selection of adolescents in a boarding setting had also different aspects. For instance, they are in the formative years of their life. If they face initial anxiety and stress, it may cause low academic performance and low self-esteem. It can also affect their grades. That is a kind of predictor of future success and earning. And last but not the least, if their unrealistic thinking patterns are identified on time, intervention is easy and possible. This study is based on Julian B. Rotter's concept of loci of control, which has two dimensions, internal locus of control and external locus of control. Those who are high on internal locus of control, they believe that whatever happens in their lives is because of their own efforts. Whereas those who are high on external locus of control, they believe that there are other factors such as luck, chance, and powerful others that play a significant role in their success and failure. The second variable of the study was life satisfaction. Life satisfaction is the rating of one's life by oneself. After literature review, the following hypotheses were formulated. Number one, there will be a positive correlation between internal locus of control and life satisfaction. Second, there will be a negative correlation between external locus of control and life satisfaction. And last, there will be a considerable difference between the level of life satisfaction of group 1 and group 2. I conducted this research on first-year students in a boarding institute. The mean age of the students was 17.38 years with a standard deviation of 0.65. 41% of the students were from pre-medical group and 49% were from pre-engineering group. The total number of students or participants in this study was 87. The measures which I used for computation of two aspects. The first measure was Levinson's, Levinson's multidimensional locus of control scales. It measured internal locus of control and external locus of control. And the second was Students' Life Satisfaction Scale by Hubener. It measured life satisfaction. As you see the graph, on x-axis is internal locus of control, and on y-axis is life satisfaction. The graph clearly shows that there is some relationship between internal locus of control and life satisfaction. Though this relationship is weak, but it is still statistically significant. In the second graph, that pertains to my second hypothesis, that shows external locus of control and life satisfaction's relationship. And very clearly, it shows that there is a meager, a minor, or minute negative relationship between the two variables. However, this relationship is statistically insignificant. Let us try to interpret why it could be weak. There could be a couple of possible reasons. For example, those who have accepted their luck and the role of significant others, their internal locus of control will not affect and will not strongly correlate with their life satisfaction. They still be quite happy with their lives, even if they have external locus of control. The sample was very small. It contained only 27 students who were high on external locus of control. Maybe the relationship between these two variables was still forming the time I conducted the study. And the last hypothesis, the study found that there was a considerable and statistically significant difference between the level of life satisfaction of the two groups. Conclusion: life satisfaction correlates positively with internal locus of control and negatively with external locus of control. Early recognition of faulty patterns may assist school psychologists to introduce timely interventions. Thank you.
Thank you, Suhail, for nice presentation. Our next presenter is Sabah Batul from Behra University, Islamabad, and she will present her topic on relationship between perceived interparental conflicts and psychological distress among university students.
Assalamualaikum everyone, my name is Sabah Batul, and on behalf of Behra University Islamabad campus, I'll be presenting my topic of relationship between perceived interparental conflict and psychological distress among university students. Following are the topics which will be covered in the course of this presentation. First of all, it is understood that positive parenting and home environment and healthy attachment patterns between parents and child and observing positive interparental relationship can have a positive impact on child development even during the early years. However, sometimes parental figures disagree with one another, which may result in quarrels and conflict. And if these conflicts remain unresolved, then they may lead to interparental conflict, which may affect the child's mental health. Research shows that the children who are exposed to interparental aggression and violence in the early years of life are 7 times more at risk to develop psychological problems and behavioral adjustment issues. Such children try to understand the interparental conflict, the effect of interparental conflict on themselves and their family, and consider it to be a threat. How to resolve the conflict and who is responsible for creating this discrepancy. Most of the cases, the child blames themselves and internalize themselves to be the cause of this conflict. According to cognitive contextual model presented by Grice and Fincham in 2001, young people's perception of interparental conflict are shaped by cognitions and a context that affects their behavior and psychological adjustments. Coming to rationale, people who perceive interparental conflict in childhood are more prone to develop psychological distress in later stages of life. Present studies examine the perceived interparental conflict on children's perception of various aspects of the conflict. This study also explores the relationship between conflict of parent and psychological distress of university students. It also highlights the problem individuals may go through because of perceived interparental conflict that affects their well-being and attitude towards life. This is the conceptual framework of the study, which shows that perceived interparental conflict leads to an increase in psychological distress. Following are the hypotheses of the study, there will be a significant relationship between psychological distress and perceived interparental conflict among university students, and there will be a significant gender difference on psychological distress among university students. Coming to methodology, research design is correlational. Sampling technique is convenient. Sampling was used, and 250 university students between the ages of 18 to 30 were considered for the study. The construct were operationally defined as follows. Interparental conflict was defined as consistent conflict between parents, which includes argument, disputes, and disagreements. And psychological distress is defined as state of emotional and psychological suffering caused by an external stressor. Here are the measures of the study. First of all, the participants were informed of the aims of the study. They were also given the right to withdraw in the consent form. Following were the demographics of the study. 2 scales were used, including children's perception of interparental conflict, which consists of 48 items divided into 4 subscales, that is conflict, threat, self-blame, and triangulation. Liability of scale is 0.85 and 2.90. And Kessler's psychological distress, comprising of 10 items, reliability of the scale is 0.91. Coming to results, the first table shows the psychometric property of the scale, including the number of items in each scale, mean score, over actual and potential range, and alpha reliability. The results show that all scales and its subscale have high reliability. Next is correlational analysis, which shows that there's a significant relationship between interparental conflict and psychological distress. Next is linear regression. Linear regression, table 3 shows linear regression. Results show that interparental conflict positively predicts psychological distress among university students, and predictor explains 13% variance in the outcome variable. LEX is not for non-parametric test, which was used to assess the gender difference in psychological distress among university students, and females shows more psychological distress than males. Now, conclusion. Interparental conflict is a risk factor for psychological distress among young adults, especially within children who experience unresolved or frequent and intense conflicts. They are more likely to exhibit symptoms of psychological distress, a higher threat, and greater conflict over time. Therefore, it is important to experience positive interparental relationship and home environment so that the child development and well-being and preventing mental health issues in later adulthood. Now coming to implication. Interventions can be designed to deal with psychological distress that arise from observing interparental conflict in early childhood. For therapists, it is also important to examine the parent-child relationship, strength of relationship, and attachment pattern between parent and child. The therapist should also take into consideration client's culture and family structure during history taking. Other than that, attachment-based therapy and relational coping strategies can be employed to decrease the impact of interparental conflict on the child. Thank you.
Thank you, Sabah, for presenting your informative work on IBBC 2023. Our next presenter is Shifa Noor from Bahrain University, Islamabad, and she will present her topic on lived experiences of psychologists about diagnosis and treatment of functional neurological symptoms disorder.
Assalamu alaikum. My name is Saifa Noor and I have done my MS in clinical psychology from Bahrain University Islamabad campus. And I've done my qualitative research in the last semester of my MS degree. And the topic of my presentation was lived experiences of psychologists about diagnosis and treatment of functional neurological symptom disorder, yani कि conversion disorder, a phenomenological study. I've done my work under supervision of Dr. Shazia Yusuf, which is my co-author for this research. So let's discuss about this topic, that हमारा rationale क्या था and what were we supposed to find out or carry out in this research. So what functional neurological symptom disorder basically is, according to DSM-5, जो कि mostly psychologists follow करते हैं, clinical psychologists follow करते हैं DSM-5. According to DSM-5 revised, functional neurological symptom disorder is a neurological disorder जिसमें weakness, numbness और seizures, epileptic seizures से resembling जो seizures होते हैं, not exactly epileptic seizures, but kind of that seizure. Patients suffer from those. और साथ में anesthesia, swallowing difficulties, motor tics problems होते हैं, और walking में difficulty होती है, hallucinations भी और dementia भी कुछ clients suffer करते हैं. Or the most important thing in this disorder that clients face is that all these symptoms जो कि client में हमें नजर आते हैं, that's not because of any biological reasons, but they're all because of psychological reasons. So this is functional neurological symptom disorder, जिसको हम conversion disorder भी कहते हैं. यानी इसमें हमारे thoughts, emotion, physical features and behavior affect हो जाता है because of psychological reasons, different trauma, और वो हम आगे डिस्कस करेंगे कि इसके रीजंस क्या क्या हो सकते हैं. Rationale क्या था हमारी स्टडी का? The rationale for study was that it was aimed to explore the lived experiences of clinical psychologists जो कि currently Islamabad and Rawalpindi and private clinics of psychiatry में काम कर रहे हैं and are dealing with conversion disorder patients. Basically कि conversion disorder के patient को या functional neurological symptom disorder के patients को deal करने में उनको क्या difficulties आती हैं और वो डिफिकल्टीज को कैसे टैकल करते हैं. एज इट इज सैड के कन्वर्जन डिसऑर्डर, डिप्रेसिव डिसऑर्डर और मेनी अदर साइकोलॉजिकल डिसऑर्डर के साथ काफी मैच करता है, सिमिलरिटीज बहुत है. तो ऐसे सिचुएशन में how clinical psychologists differentiate this disorder from other disorders, और उसको diagnose करने में, especially फिर treat करने में psychologist को क्या problems आती हैं, and फिर वो उन problems को कैसे tackle करते हैं in order to treat the specific client with functional neurological symptom disorder. So that is the reason we chose interpretative phenomenological analysis, because this research is basically dealing with the in-depth lived experiences of clinical psychologists and their treatment history, or whatever we say, कि वो कैसे convergent disorder के patients को treat करते हैं और उनकी diagnosis को confirm करते हैं. Theoretical framework में Sigmund Freud, which is the founder of psychoanalysis, उन्होंने एक theory दी थी, theory of somatoform disorders, convergent disorder के बारे में, and he said कि convergent disorder is basically a common disorder जिसको past में hysteria कहा जाता था, and its cause is purely psychological in such a way that जो client suffer from convergent disorder is basically using this scenario as a defense mechanism to hide the psychological pain, the trauma that they are suppressing. कोई childhood trauma होता है, कोई depressive situation होती है, कोई सा भी pain हो, उसकी वजह से client suffer करते हैं these from these symptoms, और जब वो बहुत ज़्यादा हो जाते हैं and it's not, the person is not being able to control, then जो symptoms है psychological symptoms और physiological symptoms में appear होना शुरू हो जाते हैं. As I said, according to Sigmund Freud, his functional neurological symptom disorder, जिसको past में hysteria कहा जाता है, that is a trauma-based condition. It's basically the trauma or trauma से related pain हमारे mind में बहुत ज़्यादा हो जाता है, which the client is unable to bear. That is why जो psychological symptoms है वो physiological symptoms में change हो जाते हैं. different researchers ने भी convergent disorder पे काम किया है different perspectives से, और and they came up with the same phenomena that जो convergent disorder के patients होते हैं, they basically suffer from these symptoms because of the psychological pain that they're suppressing in their mind. और वो साइकोलॉजिकल पेन किसी भी ट्रॉमा, चाहे चाइल्डहुड ट्रॉमा हो और करेंटली ट्रॉमा से गुजर रहे हो जो पेशेंट्स, उनकी वजह से ये पेन क्लाइंट फील करते हैं, क्लाइंट सफ़र करते हैं, एंड दैट इज़ द रीज़न कि जो साइकोलॉजिकल सिम्टम्स होते हैं जैसे कि नमनेस हुआ, वॉकिंग डिफ़िकल्टी हुआ और सीजर्स, तो it gets converted into physiological, but in the absence of any biological reason. हमारी रिसर्च मेथडोलॉजी थी क्वालिटेटिव रिसर्च डिज़ाइन था. We use interpretative phenomenological analysis because this research dealt with the in-depth analysis of the in-depth lived experiences of clinical psychologists, and data gather करने के लिए we use semi-structured interviews. We collected the data from a total of 10 participants from hospitals of Islamabad and Rawalpindi. Or inclusion criteria was psychologists and psychotherapists that holded MS or a PhD degree in clinical psychology with 5 years or above experience in this specific field. And currently that we're dealing with convergent disorder. जो results हमें मिले थे, जो common themes थे वो थे diagnostic complications, यानी कि convergent disorder को डायग्नोज करने में जो डिफ़िकल्टीज आती हैं वो सबसे पहले ये कि इसके सिम्टम्स क्रिस क्रॉसिंग है, यानी कि इनके सिम्टम्स बाकी डिसऑर्डर के स्पेसिफिक डिप्रेशन के साथ मैच करते हैं, और इसमें जो सीजर्स आते हैं, कन्वर्जेंट फिट्स आते हैं, तो वो एपिलेप्सी के साथ मैच करते हैं. तो इनके डिफरेंसेस को कैसे वो फाइंड आउट करते हैं और फिर उसको टैकल करते हैं, वो हमने इस रिसर्च में फाइंड किया. and this is basically the complication that the psychologist face कि उसको diagnose कैसे करना है, उसको differentiate कैसे करना है कि either these are the symptoms of depression or epilepsy, or these are the symptoms of functional neurological symptom disorder or convergent disorder. Misreporting symptoms means that जो क्लाइंट की फैमिली होती है, क्लाइंट इज अनेबल टू टॉक अबाउट हिज और हर ओन पेन, तो फैमिली अपने मतलब जो क्लाइंट है उनके सिम्टम्स को सही से बयान नहीं कर पाते, सही से सिम्टम्स को एक्सप्लेन नहीं कर पाते कि व्हाट दैट क्लाइंट इज गोइंग थ्रू, तो जिसकी वजह से इंफॉर्मेशन पूरी नहीं मिलती। जब इंफॉर्मेशन पूरी नहीं मिलती तो दे आर अनेबल टू डायग्नोज प्रॉपरली अबाउट द फंक्शनल न्यूरोलॉजिकल सिम्टम डिसऑर्डर। थेरेप्यूटिक फेलियर ऑब्स्टिकल्स ये है कि सबसे पहले तो मेनी क्लाइंट्स और फैमिलीज ऑफ द क्लाइंट्स डोंट बिलीव ऑन थेरेपी, दे जस्ट वांट के हमें मेडिसिन मिले and we can just control the patient or the client medicines के through. They do not believe on therapies, जिसकी वजह से भी जो थेरेपीज हैं वो जिसकी वजह से भी थेरेपीज फेल हो जाती हैं, ट्रीटमेंट फेल हो जाता है बिकॉज ऑफ देयर बिलीव्स ऑन थेरेपीज के थेरेपीज वर्क नहीं करती अकॉर्डिंग टू देम, and that is because of the lack of psychological education, because they don't know कि ये functional neurological symptom disorder is basically because of psychological reasons. तो psychological reasons को ठीक करने के लिए we need therapy. तो उनको साइको एजुकेशन को अवेयरनेस नहीं है फॉर द थिंग्स दैट फॉर बिकॉज फॉर द थिंग्स दैट दे शुड नो अबाउट कन्वर्जेंट डिसऑर्डर. Another obstacle in their treatment is unsupportive caretakers. Many caretakers of the clients that with convergent disorder or with functional neurological symptom disorder, their caretakers are very unsupportive of their conditions. They think that they are just showing up, and they think that they are just acting because of their primary or secondary gains, but that's not actually the case. It's because that they are suffering from such a pain, and they just cannot control themselves, and it happens that psychological pain gets converted into physiological symptoms, and this condition is not in their control anyway. थेरेप्यूटिक प्रोसीजर्स जो थेरेपीज यूज़ की जाती हैं इन पेशेंट्स के साथ, वो है साइकोलॉजिकल थेरेपीज में मोस्टली CBT, DBT और फिजियोथेरेपी भी if the client is suffering from motor tics, or if the client is suffering from जिसमें दे आर अनेबल टू मूव, तो उसके लिए फिजियोथेरेपी यूज़ करते हैं। एंड डायग्नोसिस को कंफर्म करने के लिए दे यूज़ डिफरेंट स्केल्स, जस्ट लाइक डिप्रेसिव स्केल और कन्वर्जेंट डिसऑर्डर के स्केल्स दे यूज़ द एपिलेप्सी चेकलिस्ट के। अगर वो एपिलेप्सी चेकलिस्ट पे क्राइटेरिया फुलफिल होता है देन दैट गोज टू एपिलेप्सी। अगर उस पे फिल नहीं होता देन दैट goes to convergent disorder. Plus a detailed intake history वो लेते हैं from the client and from their caretakers. They take a lot of time in gaining the information from their family and from the patient, from the client themselves. After that, they finally diagnose the convergent disorder. The thing that the basic crux that I want to discuss is that a functional neurological symptom disorder is very similar to depression, epilepsy, anxiety, etc. Client जो है वो suffer करते हैं from tremors, walking difficulty से, swallowing difficulty से, numbness, loss of touch, loss of sensation, speech issues, deafness, etc. So इस तरह की सिम्टम्स को लेके क्लिनिकल साइकोलॉजिस्ट समटाइम्स फेस डिफिकल्टीज बिकॉज वो एक्चुअली में कन्वर्जेंट डिसऑर्डर होता है बट दे डायग्नोस इट डिप्रेशन और anxiety or epilepsy. So to tackle that problem, they use different kind of measures and the detailed history to confirm it and then treat them with psychological therapy. सबसे पहले step होता है psycho educate करना client की families को and client itself को. The convergent disorder or functional neurological symptom disorder is a kind of disorder जिसके लिए आपको psychological therapy की जरूरत होती है more than medicine. अगर उसके साथ आपको एक्चुअल में फिजियोलॉजिकल सिम्टम्स आते हैं उसको टैकल करने के लिए मेडिसिन, बट कन्वर्जेंट डिसऑर्डर को या फंक्शनल न्यूरोलॉजिकल सिम्टम डिसऑर्डर को टैकल करने के लिए हमारे पास थेरेपीज ही काम आती हैं. थैंक यू.
Thank you, Saifa, for nice talk. Our next presenter is Taskeen Waheed from Liaquat University of Medical and Health Sciences, Jamshoro, and she will present her topic on comparative study of glossophobia among engineering and medical students.
Wishing you all a very good day. I am Taskeen Waheed, final year MBBS student, studying at Liaquat University of Medical and Health Sciences, Jamshoro. My research work was about comparative study of glossophobia among medical and engineering undergraduate students. Talking about what glossophobia actually is. The term glossophobia or the speech anxiety is known as feeling of being afraid of speaking in huge crowd in public. Glossophobia can cause a sensation of outrageous nervousness that include unique physical and verbal silent symptoms. Glossophobia can be related to the weak grip of one's own emotions. It has psychological as well as verbal manifestations. The psychological manifestations causes the stimulation of sympathetic nervous system, leading to tachycardia, palpitations, rise in blood pressure, and tachypnea. While some frequent verbal symptoms are drying of mouth, low-pitched voice, feeling dull, shaking voice because of tension, hesitational bursts, stammers or tics, and vocalized pauses that causes a person to get a strength while trying to deliver something. The causes of glossophobia can be genetic, environmental, demographic factors, and some past negative experiences in which individual was bullied during public speaking or can be combination of them all. This can cause a neglect of many academic, social, and career opportunities. The level of glossophobia of undergraduate students is worthy to be studied in order to make the specific strategies to help them grow efficiently. In this study, we aim to estimate the levels of glossophobia among undergraduate students and compare the levels of glossophobia among male and female undergraduate students, and to compare the levels of glossophobia of female undergraduate students in both different universities like Mehran and Plums. In this study, 200 undergraduate students participated from Liaquat University of Medical and Health Sciences, Jamshoro, and Mehran University of Engineering and Technology. We collected our data by using personal report of public speaking anxiety questionnaire proposed by McCroskey by using simple convenient technique. Our study model was comparative cross-sectional type, and in the end, we analyzed our data by using SPSS software. We included students only from Liaquat University and Mehran University with the age limit of 17 to 26 years, while we excluded all other students along with postgraduate students and professionals. After getting the scores from the PRPSA questionnaire, we categorized them into 5 categories. The scores between 34 to 84 were labeled as low anxiety, while between 85 to 92 were labeled as moderately low anxiety, 93 to 110 were labeled as moderate anxiety, with scores between 111 to 190 were labeled as moderately high anxiety, while the scores beyond 120 were labeled as high anxiety. Generalizing these results, we got that almost 28% of the students were experiencing low anxiety during public speaking, while 32% students were experiencing moderate levels of anxiety, and a huge number of almost 40% of students are experiencing high anxiety during public speaking. Moving forward to find the association of claustrophobia with other variables like gender and different universities, we got that almost 75% of the female undergraduate students were experiencing high levels of claustrophobia, while the male undergraduate students were experiencing moderate to low anxiety levels. Moving forward to find the association with the different fields and universities, we got that almost each category has a similar number of students. So in order to confirm their findings, we applied independent t-test and we find out that claustrophobia has a significant association with gender, which has a p-value less than 0.01, while no significant association was found between claustrophobia levels and fields which had the p-value of 0.875. Based on these results, we concluded that claustrophobia was found to be more prevalent among female undergraduate students. Male undergraduates showed the low levels of anxiety, while university and difference in the fields had no impact on the levels of claustrophobia. Based on this study, we recommend further studies because our study was limited only to the Jamshoro. So we recommend that certain studies should be conducted nationwide to generalize these results. Further studies should also include younger age groups to find out the root causes of the claustrophobia, and the students should be given certain opportunities to practice public speaking in a safe, supportive environment, encouraging them to develop confidence in their public speaking by focusing their strengths and providing positive feedbacks. Different seminars and workshops should be arranged to help them managing anxiety by teaching them relaxation techniques. So this was all about my research work. Thank you for having me here and making till the last.
Thank you so much, Taskeen, for providing us information. Our next presenter is Shamsur Rahman from Liaquat University of Medical and Health Sciences, and he will present a topic on association of stress and insomnia with emotional coefficient among undergraduate students of Liaquat University of Medical and Health Sciences, Jamshoro.
Assalamu alaikum. Start with the name of Allah, the most gracious and the most merciful. Welcome you all to the International Brain and Biomedicine Conference 2023. My name is Shamsur Rahman. I'm a final year MBBS student at Liaquat University of Medical and Health Sciences, Jamshoro. Today, my topic of presentation is association of stress and insomnia with emotional quotient among undergraduate students of LUMS. What is insomnia? Insomnia is defined as a sleeping disorder in which one may experience difficulty in falling asleep, staying asleep, or getting a refreshing sleep. Long-standing insomnia has prevalence of 10% among adult population. Temporary insomnia may be due to stress or changes in schedule or atmosphere, which can last for a few days or weeks. Chronic or long-term insomnia occurs 3 or more nights a week, but lasts for more than 3 months. Insomnia has great impact on one's memory, concentration, and focus. Chronic insomnia raises the risk of health problems like blood pressure, diabetes, and chronic heart disease. Insomnia is a multifactorial disorder, mostly caused by psychological stress. Medical students tend to experience great load of academic stress, which lead to sleep disturbance. That's why insomnia is much more common in medical students. It's been found that stress and insomnia both have negative impact on emotional intelligence of students. The students who are having low EQ are facing reduced self-awareness, not good in managing emotions, not motivated always, no empathy for others, they have low social skills. These are the some objectives of our research articles. Number 1, to evaluate the association of stress with insomnia. Number 2, to assess the association of EQ with insomnia. Number 3, to determine the association of stress with EQ. Our study was conducted at Liaquat University of Medical and Health Sciences, Jamshoro. Our study design was comparative cross-sectional study. Our study period was from 15 August to 31st October 2022. Our study population was the undergraduate students of LUMS. Our sample selection was through online questionnaire. Our sampling technique was non-probability convenient sampling. Our sample size was 167 students. The inclusion criteria for student was their age limit between 17 to 26 and the undergraduate students of LUMS. Exclusion criteria, age below 17 or above 26 and the postgraduate students of LUMS or other universities were excluded from this study. The data was collected through online questionnaire. Regensburg insomnia scale was used to measure the level of insomnia in students. Perceived stress scale was used to measure the level of stress in students. Emotional intelligence questionnaire was used to measure the EQ of students. The data was studied and analyzed. All variables, including insomnia, stress, and EQ, were observed and compared through SPSS software. Moving forward toward the result section, we found that 57.5% of the students were found having insomnia. It means that the frequency of insomnia is much more common in medical students. The pie chart shows the ratio of insomniac students versus normal students. Let's discuss our main objectives. Association of stress with insomnia. By analyzing the data through SPSS, we found that a positive correlation exists between stress and insomnia. A significant p-value is 0.05. Look at the graph at the left. The students who are having insomnia are represented by green color, but the students who are having normal sleep pattern are represented by blue colors. According to perceived stress scale, stress is categorized into 3 groups: low stress, moderate stress, and high perceived stress. A certain degree of normal or physiological stress was present in both group of students, but those who were found insomniacs were having higher degree of moderate stress and high stress. The graph on the right shows 60% of the students who are experiencing more stress were found insomniacs as compared to those 40% students who are experiencing normal stress, so they have normal sleep pattern. Association of insomnia with EQ. We found that insomnia has negative impact on the EQ of students. A negative correlation exists between insomnia and EQ. A significant p-value is less than 0.01. Look at the graph here. Again, the insomniac students were represented by green color, while the normal students were represented by blue colors. Out of 96 insomniac students, 74 have low EQ, 18 have moderate EQ, and 4 have high EQ. It means that the students who are experiencing insomnia, they have low EQ. Association of stress with EQ. A negative correlation between stress and EQ was found. A significant p-value is 0.01. Look at the graph. It shows that the number of students who are experiencing moderate stress or high perceived stress were higher in number who are having low EQ as compared to those who are having moderate or high EQ. So stress also has negative impact on EQ. We concluded that high level of stress impacts sleep pattern of medical students and it is important cause of insomnia. Furthermore, insomnia and stress both have negative influence on emotional intelligence that suggests they are the root of decrease in EQ among medical students. Recommendation. Unfortunately, poor sleep quality greatly underreported among students and there is widespread ignorance about insomnia in our society. Seminars should be arranged to spread awareness about sleep education and its positive and negative impact on health. Different seminar and workshops should be arranged to help them managing stress and tackling with difficult situations. Students should be aware of the importance of stress management. Healthy environment for students should be provided to flourish. Course a scheduled student should be student friendly. Further studies are required to find out other factors responsible for sleep disturbance. These are some references which were used in our article. So this was all about my research work.
Thank you so much, Shamsul Rahman, and thank you all of you for listening.